You see, everything goes back to a masterclass program which we do every year with the University of Cape Town. Edelweiss was developed to really reach out for the broad population. It's not a system which was just developed for about 20% of the people in this world. So this is just a perfect example how we can, bring back a smile into a patient's life and make him happy again. So we keep what is there and we just add what is missing and correct with the restorative material, position and aesthetic. So welcome everybody to this session of today. I'm really proud and privileged to have you all as a member here in this session. Today will be a very fruitful day as we will discuss a case as well as we do a live session. So I will treat a case from A to Z with the veneers in a direct method. We will learn that there is different methods, direct, semi-direct and indirect. On top CAD/CAM block, so the digital workflow is also possible, and it all based on the same core competence of the technology which Edelweiss provides and which of course is fruitful and beneficial for dentistry.
We are excited as much as you are to present this afternoon's lecture to you. As Stephan mentioned, our focus today would be to take you step by step. So from the time the patient walks into your office till the time she leaves. So we will show you from the time when she walks in how to examine, how to do the treatment planning, and how we will communicate with the laboratory. And then we'll show you step by step how to place those veneers and till the final smile. So that is what our focus is going to be today. We will, three of us, be giving commentary throughout the session, so you would know step by step what is going on. And of course, we'll answer all your questions at the end of the session.
My part is I'm going to show about how to use the articulator, how to change the vertical dimension, and how to do then a splint, why we do a splint therapy, and so on. Thank you.
As we said earlier on, our focus is not so much to give you a formal lecture, because you've had these formal lectures throughout the series. So we thought today we will have like a discussion and walk you through the process from the time, as I said, a patient comes in till the time she leaves. So we will focus step by step on each process. Now, of course, as you mentioned, we have two master internationally acclaimed practitioners. Stephan Lampl is a world-renowned clinician and he spoke all over the world. And of course, Martin Lampl is also internationally acclaimed dental technician. So I have what I nicknamed the Michelangelo of dentistry on my right-hand side and the Da Vinci of the technical side on my left-hand side. So could you imagine today we have a Michelangelo and Da Vinci in dentistry for you. So I am excited as your guys are. So let's start with our first case. That's a case that Stephan did a couple years ago. And now I want Stephan to discuss what his thought process are when this patient walks into your room. What were you thinking, and how would you try and get him to get a better smile?
Right. So when we look at this patient, before we even have a closer look to his teeth, of course we can already see that there is heavy abrasions, and also, you know, just from the chin line, everything what you see from the side profile, you see heavy abrasion. You see how the lower jaw is more and more protruding, and actually this is what we need to get under control. Of course, effects and symptoms which the patient explains at the same time is headache, his tension in his back, etc. He's in therapy with physiotherapists and so on. And this is just something which we find out during the discussion with the first talk we have with our patient. And then, of course, by surprise for the patient, most of the time is that we can find the reason for all those symptoms mainly in his bite. So when the bite is wrong, there's a lot of things which come into place which have effects to the full body, and of course those patients are suffering from that. And of course that is our aim, to overcome all these problems and to solve it. And this is what we need to do when we look at this bite in a closer manner. And then of course we can see now, all of us, that he has heavy abrasions, that he's bruxing for years, and now you can imagine the guy is end 30, so another 10-15 years, so more or less nothing will be left from his teeth. And of course the teeth at the same time get more and more sensitive, and now it's really time to do something. But at the same time, when we do such cases, it's a full mouth rehabilitation, and this is also something which is financially a big effort for the patient. So our aim was, of course, to solve these problems with a therapy plan which we have in place, which we have more or less progressed over generations. We are now in the third generation doing dentistry, so that was really the main task also while we developed Edelweiss, because Edelweiss is just a consequence as a system to solve these cases in a situation for the patient that he can finance it. So that we can strictly, act according ethical behavior in working minimally invasive, to really keep what is there and just add what is missing. And with the restorative material, we correct bite, function, and of course on top aesthetics. So this is the main goal which we all have. And of course, the first thing we do is that I take impressions, and it's important that the impressions are properly made so that the vestibulum is visible, and that of course all the gingival lines and everything. So really a master impression which returns in a master model, and then we can do all the measurements. Martin will talk more about the measurements where we analyze the correct arrangement between the lower jaw and the upper. And once that's adjusted in the articulator, we can create a bite splint. So this is not just a bite splint which we see often, which is just, like a mouth guard keeping the patient from abrading his own teeth, but of course abrading the acrylic. This is really a therapy splint. This is a splint where we reprogram the brain to a new bite level, and of course at the same time we build up the muscle functions. So we will all talk about this later on with the articulator in combination, but actually this is the first step. So we get this splint, and the splint is what we provide the patient in a first step. It takes about, let's say, 3 to 4 weeks until the patient can really benefit from that new bite level, and when reprogramming of the brain, so to speak, of the vertical dimension takes place. And then the patient is turning into a relaxed bite position. So all his muscle functions, etc., will be relaxed. And of course, sooner or later, we need to replace that splint with our restorations. But the aim here again is we do this without even prepping those teeth. So it's a strictly additive procedure where actually our occlusion VDs and our veneers act to replace the splint. And of course, due to the biomechanical approach, once they are cemented, we are generating a monoblock, which means we have from the tooth to the restoration, throughout the restoration, the same mechanical behavior of the material in combination with the tooth. And that's of course, especially with such patients, very important. Because, natural teeth are not made from zirconia or ceramic. It's flexible. It's, you know, we all know how hard ceramic is. And of course, it would not allow us to work so minimally invasive. We need to prep much more. And if we just go with regular composites, they are also too weak. I mean, they are on the softer side, but of course we generate great adhesion. And so we follow strictly the natural mechanics. So what we add is really mimicking, and then of course is integrating into the mastication system in the best way. And so we have achieved with the system a therapy plan, and of course on top a solution which is affordable for the patient, which solves his problems in regards of his mastication functions, and of course on top of that he creates a beautiful smile. So here we see the occlusions which sooner or later replace the splint. So actually the splint is prepared or created according to norms which we measure. As I said, Martin will talk about this while I'm treating the patient in the next session. So we have to replace that splint sooner or later with occlusions which are just overlapping the existing occlusions and of course replacing the splint. The splint is made according to a norm. Now when the patient is having that splint for a time frame of about 3 to 4 months, he leaves his individual footprint in that splint, and we use that splint to re-articulate again, and then we create those occlusions, and they can be prepared via the occlusion VD, so the prefabricated, and we reline them. That's so the manual way, a semi-direct way, or we go with the CAD/CAM blocks. So then everything is done digitally and we just mill them. And then of course they individually fit already to the existing occlusion. And then it's actually a quite easy progress or treatment plan, because we are just cleaning, etching, bonding and placing those restorations, following up with the veneers. And so we have now fixed the vertical dimension which we have achieved with our splints together with the patient, and of course now the patient have a fantastic feeling, is now in a parallel situation of his upper and lower jaw, and of course that also keeps him from grinding. And the case we are looking at right now, this is 3 years down the road. There is also interviews with him, so you can from all sides check this case, you know, from the patient side, how he experienced now after 3 years. And what you have here is also the pictures after 2 years already. And you see those restorations are beautifully in place. They are beautifully shiny. Actually, that's just, as I said, the side effect of the treatment, that he has a nice aesthetic design now, but most important is always the function, and this is what we could solve in this case for this patient, as we do it for hundreds and thousands of patients all over the world, because actually we are dedicated, probably 80 to 90% of our treatments focus on such cases which are coming to our office because they don't find anybody else, or only short, let's say, colleague base which can help them in such a phase. But again, so this system was mainly developed for these kind of full mouth rehabilitations. And of course, we don't have to go always for those, let's say, huge setups. Mainly, or many times, we just do veneers, or we do single occlusions, incorporate them in an existing bite, because of course not everybody has this bite issue, but a lot of them have it, and this is an affordable way to solve their situation.
Yeah, thanks, Stephan. You mentioned that the benefits is to the patient, that's very affordable. Mm-hmm. And also from a functional point of view, that it mimics the natural tooth.
Right.
So the patient doesn't feel uncomfortable after wearing it. I'd like to add there, though, the benefit to the dentist, in the sense that it's so much easier to place. Yeah. Number one, as you mentioned, you can do direct, according to how you feel comfortable as a dentist. You can do direct, you can do semi-direct, or you can do indirect. Exactly. So the choice is yours. That's number one. Number two, the big benefit also is choosing the color, the shade. There's no mismatch at all, because for the first time now in the history of dental materials, the choice of shade matching is in the dentist's hands. So there's no mismatch, and I have to send it back to the technician to say, I'm sorry, the color is wrong, we have to redo it. That just costs extra, there's extra cost. And a very big saving as well to the dentist is the time.
Yeah.
It's minimally invasive, so you don't need to prep and cut a lot.
Yeah.
So you save a lot of chairside time. So there's more patients coming into your room, so it's cost saving
Yeah.
again.
Yeah.
So it's benefit to the patient, to the
Absolutely.
dentist, and
Yeah.
just overall function. So let's discuss now the patient
Yeah.
that you want to see today.
Exactly.
Okay. So this is the patient that we're going to be looking at today. She's on our chair there, and Stephan's going to walk you through the process
Yes.
of pre-examination and treatment planning, and then we'll follow up with step by step.
Absolutely. So again, today we have a patient where we will, solve the smile. Of course, we will do this with our veneers. I will solve this case directly. So I will just take the veneers in the different sizes which we have, extra small, small, medium and large, and adjust them chairside, and then I apply it. Of course, I could also take impressions and just ask the lab to mill those for me. Or of course also they can adjust the prefabricated veneers to a model. This is what of course we can do also at the clinic. But today, as I said, I'm going to focus on that case, and when we look at her smile, then we can see and of course, one of the central is very exposed, slightly rotated. We see that the gingival line is kind of, very irregular. And before I start such a case, of course, I do a bit of gingivectomy. So this was done a couple of days ago to leverage everything. And you can see also that there is a bit of decay in the central. So I removed that initially already to be prepared for today and cleaned that out and just, built up that corner with a bit of composite so that's like a direct restoration. And then, of course, I'll just let the patient go for a couple of days, and today she's back and everything is beautifully healed. You will see now the new gingival line once I'm gonna step over to her and starting the treatment. But again, we can solve her aesthetic issue with gingivectomy and then using the veneers. The beauty of those veneers is that those veneers are all made according to the golden proportions. Of course, when we started out this project with prefabricated veneers, we, checked thousands of anterior teeth from different nations, let's say different people in the world, and so then we came up with a quite universal situation or universal shape, and this shape is, as I said, according to the golden proportions. And now we can grind those veneers or mill them with our burrs towards the initial situation which we face, so we can make them a bit slimmer, a bit shorter, etc. And then of course they will cover the entire tooth surface, and in the end of the day we are just relining with the shade we are looking for. So the veneers, according to the natural layering principle, we have an enamel shell and we underline with a dentin shade. So we have a beautiful, arrangement of translucency and opacity from the lower material, and of course that provides us with a beautiful shading. And of course we can do this kind of digital smile design already with our patient without photography, of course, because we have those veneers available and we can just take the prefabricated and reline them with a bit of composite and place them like a direct mock-up. So the patient immediately can see how she could look in the future. And that's more impressive than any picture, because the picture is still 2D. But if I take the prefabricated veneers, reline them, place them, like just mock them up, then the patient can take a mirror, look in the mirror. Of course, it doesn't feel his own teeth yet, but of course, he's just a step away to get that feeling once they are placed. And so that's, of course, also for us a very good training, because we can already, see where we end up using the size we have selected with the different shade. You can also change the shade so the patient can analyze, okay, how would I look with an A2? How would it look with an A1 or even with an A0? So you involve the patient in the final outcome, because what we use underneath our veneer is the highly filled restorative material, which of course provides the shade throughout the translucent veneer. And so this is a very good start when we getting in a patient and he's interested for that kind of treatment, that we have those those sets available. We just reline them and we place it, and the patient is involved from the start of the procedure. And so he's part of everything we are doing, and this is what we exactly did also with our patient of today, and that's where she made her decision to go for it and to receive a new smile with our veneers.
So this design software is quite expensive to use. And so with the Edelweiss system, we can bypass the system. Of course, there's a lot of a learning curve as well when you buy the system.
Yes.
With the Edelweiss system, we can bypass this digital smile design and sitting on the computer and working all that. What you're saying is we can put the veneers directly in the mouth, do a mock-up, and the patient will see exactly what she will look like at the end, not using a photograph. So your way, or the Edelweiss way of doing it, is more impressive to the patient. Because that will be the final outcome that you will get. It's not showing photographs. And it's not spending expensive software. You're taking your veneers, placing it in the mouth, showing it with a mirror, and that's what you're going to walk out with.
Especially if you do it only one side, you see, because then they have a before and after in one view. So they see, okay, this is how I could look like, and this is how I still look. And so this is, I think, something very impressive for the patient, and of course also for us. We can already see what the outcome will be. On the other hand, if you do this very clean, I mean, if you reline the veneers properly and you seat them and you take the surplus material out of the way, you separate with a mylar strip in between the teeth, and you cure that. So at that stage you haven't even etched the tooth, nor bonded. So what it means is you can take those veneers off, and now the material which you have relined under the veneer is like taking an impression of the overall tooth and the gingival line. So now you can use the veneer, shaping it accordingly, down to these margins, and then you have a semi-direct approach, because now you are coming back with the veneer which is already individualized of the situation. So that's also a very smart approach. So if you are afraid to go, direct with etching and bonding and placing, this is always a step you can do, and you're not losing anything. You have the veneer, it's kind of a reline, you have that impression taking due to the composite material which is already cured, and it's easy to take them off, as I said, and then you finish them and you bring them back into the patient's mouth. So you use the patient's teeth as your model. So what I describe here is, the system is really allowing you to work in all directions, which is very forgiving at the same time. You learn, you see, you can, step by step progress yourself to do it like I do it today.
Can you see why I say he's a Michelangelo of dentistry? A technique that I never thought about. Excellent. So you place it, you reline it, you can see exactly where your gingival line is. You trim it out of the mouth, then you just sim it. So you've got a perfect smile, a perfect end result. Not wasting dentist chairside time. You know what the end result would be. It's a win-win for the dentist and the patient.
Absolutely.
Wow, that's fantastic.
It's especially, when you have cases with huge diastemas. It's very helpful, because most of colleagues, or a lot of colleagues, fear these things, how to, coordinate the gingival line towards, closing, so that you don't have any gaps or something like this. And this is something where you add and you can take away. So it's really a semi-direct. We know this technique also, taking an alginate impression using a bite registration material, so a very hard silicon, to take a model from that impression, and then you can do it on the model also, relining and bring it back. But you can use just the patient, so you always save time, you save material, and at the same time you demonstrate, and the patient is part of it, and I think that's, for communication, the best thing.
At the same time, you could also make it easy when you pass it over to the dental laboratory. So they could do it for you, and their time is less expensive than your own time on one side, and the other side you have the digital possibilities, where you have this design already on our software in the lab, and you have the same result, and then it fits perfectly. And then so you have again also this solution or this possibility.
And then all the dentist needs to do is just cement one, that's all. Because you've done all the trimming. The hard work has been done, so they just need to trim it. So it made it very easy for the dentist itself. So that saves the dentist time as such. So there's two possibilities. That's a flexibility about the Edelweiss system that I like, is if you feel you want to do it in the chair, you can do it. If you want to send it to the laboratory, you can do it. So you've got the flexibility to play with depending on you and what you want to do.
Yeah.
So you can play around with
Right,
quite a bit.
right.
So Stefan, we're going to move to your patient now. So while you're moving and getting yourself ready, Martin will be talking about how to open up the bite and
Super.
is that
Perfect.
and then you can discuss because this is a question I get asked quite often all over the world. That is, dentists want to know how to open the bite, how much should I open the bite, and also the use of splints. They're not sure whether I should use an upper splint, a lower splint. Should it be soft, hard? So these are the questions now that we're going to be tackling. Martin is an expert in this, as I said, and he will show you step by step how, when he gets the impression from Stefan, how he articulates it, what type of articulator he likes to use, and then he'll show you how he fabricates the splint itself. Okay, so over to Martin, and then I'll change the slides whenever you are ready, or you can.
Yes, so this is, when we talk about vertical dimension, we talk automatically about muscle problems. We have the different symptoms, like Stefan mentioned already before, from migraine, headache, neck ache, backache, and so on and so on. We can have a tilted hip because of a wrong bite or of a interference of a pre-contact and so on. And these things you must analyze finally in an articulator. That's because in the mouth you cannot just lift the bite left and right side exactly the same way or the same height. It's very, very difficult, and it's not to propose. So we do in the lab, of course, when we have an impression, we do a plaster model. On a plaster model we can see everything. We can see all the abrasions which you see here, and this case, for example, is an 18-year-old student, and he is bruxing, and we see all these problems, and if he will continue like this, of course, he will come quickly down to the dentin, and then it will be painful, and all the vertical dimension is lost, and so the problem starts. It's a slow process, but it's a very efficient process in a negative way. And when we see from this side, we see the abraded canine here, and we see the big step to the first premolar. And we know, we learned once what's an ideal occlusion, what's a Spey curve, what's a Wilson plane, and so on. And we just need to take this knowledge, which we studied, these are the basics, and so we with this knowledge we can change the situation in the articulator. So, for example, this is a case where I just show you a big problem. So this wisdom tooth you see here, he causes a big problem for the muscles, because it's like when the patient is chewing or moving, this is like a rock on his way, and he has all the time go around. So that's why the solution here is not the splint. The solution would be just eliminate this or extract this wisdom tooth, and you will have a very big successful changement for the patient, which causes really pain for the muscles.
So now, as we said, I'm just quickly stopping. So you saw the before, and I just wanted to mention that actually I did the gingivectomy here, and now you see that one was so much higher, so I followed up here with the laterals until the canines. So that was, let's say, the previous work. I just did this a couple of days ago, but that's of course the beginning. And as I said, I took out the decay here and I cleaned it up and just built it up with a composite until we are now placing the veneers. So all I'm doing is actually roughing the teeth, what I already did before you were joining. I used my sizing guide, and where is it? I just had it here. So to select the right size, you see, we have these sizing guides. They are representing the different sizes, and actually what I use for her is the small size, as you can see already here in the centrals. I think that should be visible, so that just allows me to select the right size. And that's again also, those guides are according to the golden proportions. So I use the small size. And I start, in this case, with roughening the teeth with a diamond burr. So you see, all I'm doing here, I'm following up here on the gingival line, and I go along the tooth surface, just slightly roughening. So there is no preparation done, just really with a fine diamond, I go over the teeth and just make sure that I have a clean surface, and that will be followed with a little bit of phosphoric acid, which I'm gonna apply for 30 seconds. So that's all. You see, I'm not going underneath the gingival line, so I'd use a flame, a diamond flame, a red one, thin one, and that's it. And really just, slightly roughening. I go over the incisal edges here. That's it. Nothing more. Okay. So we have already selected the right size, which is an S. And in her case, as I do not have to match her initial, or let's say her original tooth color, because you see nowadays most of patients, they ask for very white shade. So also her idea was to have the A0. This is the dentin shade which we're going to use today. And this is why I'm not entering too much into shade selection. But otherwise, this is what we have. This is the shading guide. And this one always represents the veneer, yeah, this tool. And then you have those different dentin samples. And it starts out with the A0 and it goes down to A3.5. And if I would now actually want to meet exactly her tooth color, then I'm going to use my shade guide, go towards the cervical area of my patient's teeth, and there I select which one is the right one. This is, for example, if I really want to match perfectly, or I have only one single veneer which has to match towards the neighboring tooth, and actually now I'm just using the A2 here. And I will now implement, I will now use my shell, implement, and now I can check the combination, and then I can see, okay, this is where I go. Yeah, so that would be with the A2. But as I said, today we use the A0, as she wants to have white teeth, bright teeth, and overcome the discoloration. We will later on also do the lowers for her with veneers, but today, as I said, we just focus on the upper. So now I have actually cleaned the teeth, and the next step is that I use my veneers. So this is just the box of the direct system, small size, as I have selected, and all I'm using now is out of the box my veneer. So I'm just placing it like it comes out of the box. I have a look and I can see, yes, it's covering the entire tooth situation, and this is what I just said before. I could now reline this, place it, clean it up, and of course the patient can already see how this could look like. Or I could even cure, take it off, shape it, and then cement it back. So now there is only minor adjustments I have to do. One of the adjustments is here towards the middle line. So the width is a bit too much, and also here I will slim it. But the length is already perfectly, yeah? So now all I'm using is a round diamond. And hold on. Okay. So okay, so I use the round diamond and I will take my veneer. So I will do this now in front of the patient. Normally you can do this already towards the study model. But all I'm doing now is actually, first of all, take a bit from the midline. Yeah. Okay. And as I told you, I do it a bit, I will slimmer it a bit. So I'm gonna along the mesial and distal line of my veneer, also in the... See, this is the beauty, because you can adjust them without fearing any fracture of the veneer. And if I now double check again, so now you see my width is good, it's not overlapping, and I cover the entire tooth of my front teeth here of the patient. So that's it. So now I will just go in the internal side of my veneer and create a bit more space. So I'm gonna also remove a bit from the inner part. And at the same time I'm roughening, of course. And while I'm roughening, I create the mechanical retention for the bonding, which we're gonna apply later on. Okay, so now just cleaning that quickly, and so I can have further integrated the veneer now, and this is, yeah. Now I'm happy with the fit, and of course now I can proceed relining that veneer. So now I will start to etch the teeth. I'll just isolate the premolars. So remember, I started out roughening them, and now I'm just gonna go and etch them. I overlap the incisal edge with the etching, because of course we're gonna lengthen a little bit the incisal edge, so I'll just make sure that also there I have a good adhesion performance. So now we're gonna leave that on for 30 seconds. Yeah, very nice. So you see, this is all in real time, so it's really live. And I'm going to now remove. So now, many times the questions arrive, okay, do I need to use now retraction cords? And well, we don't need, because I have developed this kind of technique, which is quite simple, that I use my mylar strip in an opposite way. So instead of going in a loop shape from palatal to the facial, I'm going straight away from the facial side, you see. So now, of course, I have a perfect field, isolated to work. The gingival line is now isolated from my mylar strip. And actually now I have a good position to insert my veneer. At the same time, all these margins will be automatically sealed, and my surplus material will be guided, of course, due to the strip. So that's a very easy thing, and so I don't need a cord, because that's exactly my border, the mylar strip which I have placed. So now I will just reduce the light a little bit, because we are now working with the bonding, and I'm applying now a dentin enamel bonding here. You see, I'm just going along entire tooth surface, and still you see we have this coloration here. Yeah, she was a child, she had an accident, she fractured her front teeth, and well, that was built up with composite. You can see this also on that edge. So that is still fine, so we left it there, but you will not notice any shade difference between the, let's say, the two centrals, even though the one is more discolored than the other, because the restorative material, which we use as a cementation material, is not only providing us the shade, it's also blocking out the miscoloration. At the same time now, I'm going to use my veneer. So this is the one we have just adjusted. But in this case now, instead of using a dentin enamel bonding, I'm using the veneer bond. The veneer bond is a bond which is not containing any alcohol or, let's say, ethanol or acetone. So it's not a bond which was designed for the tooth, a hydrophilic one. No, this is a hydrophobic one. So it's resin composed with silane, and that of course provides us the best adhesive bridge from the veneer towards the restorative, and then from the restorative to the tooth we have our dentin enamel bonding. And on top of that, that bond is transparent, so it doesn't have any yellowish tint, so to speak. And well, remember, those veneers are laser sintered. So this is not just a composite which is light cured. No, this has no more free radicals. This is sintered to a level that you have one single glass face. So there is actually no more resin inside. It's just the pure sintered glass, made barium. And so after curing, of course, I have different opportunities. I can now use effect shades to align the veneer from the inner side here. Of course, I can do this also in that area, that I use effect shades like the ice, or let's say the white opaque. So there is all kind of variations available. But in this case, as she's looking for a real white, you know, for that A0 shade, I will keep that out today. I get the natural translucency already from my veneer, and as I said, I'm just going to reline that now with my A0 material. So you can see from the tip, this is the Edelweiss material, 83% filled with glass. And what I do is I make sure I have clean fingertips, so I always have an alcohol wipe available. And now I'm applying a stripe, not too much, small portion. I fold it, yeah, like this. And now I have my veneer, which I have also now in my hand, and I will just add that ball into it. So now it's perfectly sitting there, and I will just now apply that layer. So I'm not using a flowable material to cement, no, high filled, and again the shade A0. So I place it in a thin layer, and what is too much, I just take away. You can see that all looks good to me. So now I will just add it to my instrument like this. And as you see, we have this beautiful setup now. And I come in with the veneer, I place it, and now you're in control. And now I shift the veneer more and more. You know, the material gets warmer underneath. So due to the body temperature, composite gets softer, and now my surplus material is driven by the mylar strip to the right position. So mylar strip is the natural border to the gingival line, and that allows me to work without any cords in this case. And you can really press it more and more. And at the same time, as I press, I can follow up here how it nicely seals my margins. Yeah. At the same time, we're going to have a look from the palatinal side. So of course there is surplus material, which I will now remove. Take it. And you have working time. You see, of course, I have reduced the intention of my OP light, but at the same time, I'm still working very relaxed because I'm not fearing that this is gonna cure. Okay, and the first veneer always takes most of the time. Let's say the first two, as this is exactly where we start out. I just check once again. Okay, so now I will ask my nurse to just cure through the incisal edge. And always from upside down, yeah, like this. Because, yeah, you can stop. If she's doing it like this, then it makes no sense. No, it makes no sense to cure. Because what happens? If you cure this way, you will polymerize all the composite down. If you just cure that way, you spot cure here, and here it's still soft. So you are again having a second chance to clean out something if a problem is there. But now my veneer cannot move out of position anymore because it's tech cured, so to speak. And this is also a very helpful situation. So I'm just making sure all is clean. Perfect. Okay, and now we go for final polymerization. Excellent. So I can remove my mylar strip. I can check the situation. You see now if there is a bleeding, it doesn't mind me because, of course, I have seated everything perfectly. And before I just go to the next one, I will use my Soflex and quickly finish off the surplus material, which is very minimal because you see, due to the mylar strip which I have placed, as you have seen, I have a perfect situation. Okay. Same time I will quickly follow up on the gingival with my diamond. And also I will use a strip. Go through the interdental areas before I will follow up with the next central. So that looks very nice. Okay. So now I will just follow up with my next veneer. So in the meantime, I was adjusting all the veneers like the one I have showed you at the beginning. So now we need a new mylar strip, much longer. This fits good. No. I show you one more and then we're gonna quickly step over to the discussion again. You will still see what I'm doing, but now it's actually repeating what I just did with the first one. Again, I think that's a very useful trick. Use that mylar strip in the opposite way. As you can see it one more time. And again, this is isolating the entire area. As you can see, it provides you a perfect borderline. And again, I will just proceed with the next one. So my next veneer, I have also adjusted the same way as you have just seen before, and I will just trial fit it one more time for you. And this looks quite nice. as you see, and I will now just proceed with the bonding procedure. Okay. For example, when you have not these kind of tight contacts which I face now, then you can always fit or fixate the mylar strip with so-called wedgets. I will show them later on, I don't need them right now, but with other cases we can use it. So again, you see I'm working into that window, so to speak, and just making sure I apply enough dentin enamel bonding. Again, all is isolated. Okay, like your okay, so now I will just also bond the veneer again with the veneer bond as already mentioned before. So again I'm add the bond into it. Gently air dry, so don't create any bonding legs in the veneer, just a thin layer. And now again using the A0, again applying amount of material onto my fingertip, and I'm just picking up the veneer, and again in a very thin layer I apply it, making sure the entire inner surface is covered with a thin layer. Yeah. And again I use my instrument, fix it like this, and I come in again like this. Shift it into position and now press it. Okay, super. Okay. And as I said, you don't have to rush because you have all the time to really. And then I add surplus material. And of course, in the beginning, you will have more surplus material because you need to get used to how much you really need. You see, and what is too much there, I can just also easily remove. Okay, we do again the spot curing through the incisal. Okay, and now I can double check. All is good, and we go for the final curing. Cool. Can remove the mylar, clean out. Okay, looks quite nice. I don't know if you can see that also. Okay. again, I use my strip. So once the veneer is placed, of course, it's just really to remove the surplus material. And you can just proceed. And now, of course, it's getting more and more simple because first samples are there. Let me see it also. You see from the inner part. I don't know if you can see it also, if this is visible. But now we have really very nice setup. Yeah. So now I'm going to go with the lateral. So I'm just going left and right. Bring in the next mylar strip. Yeah.
You see this occlusion despite the relation mandibular-maxilla. It's obviously it cannot be an ideal or a perfect or a correct vertical dimension. Oops, back. I just want to. If you see this third premolar, for example, he extruded, of course, because there is no antagonist, there is no other third molar. So imagine when the patient is chewing what this is doing for the TMG, or especially because muscles protect the TMG as much as possible. So this causes big symptoms, big problems with this interference on one side. On the other side, we see this big deep bite position. So what we can do with our basic knowledge, so this is a Middle European average of vertical dimension. When a dental technician starts to learn their job, they start with this basic knowledge. When we do, for example, a full denture solution or full denture upper lower, then we know with our wax bites we have these measurements of 18 in the lower and 22 millimeters in the upper from vestibulum to vestibulum. You have, and that's why it's important also for us that we have in the model or from the impression also all this information like the vestibulum also in the anterior area, because there we have reference points where we can really measure and equilibrate and change the position with help of our articulator. So this is a old SAM articulator. I really like this because it's very simple and uncomplicated. If you see this little insert here, this yellow thing, this is like a protrusion insert. It helps me to change or idealize the bite. So we can do the same with Artex. This is just a fully adjustable articulator, which allows us to protrude with this screw. I'm going to demonstrate this just directly later on. So when we come back to this case, we see now how we change this in the articulator, in our SAM. And now we have the measurements. We measure from the upper cervical border, from the anatomical crown to the lower cervical anatomical crown, and then we measure about 18 millimeters. Or we have the vestibulum to vestibulum, or let's say subnasal point to the pogonion, we have about 40 millimeters. Of course, we are not in a norm, and of course, we are not need to put everybody to this 40 millimeters. It's just also with logical thinking. When you see and check the overbite and overjet, and you know an overbite of 1 to 2 millimeters, then you can go, sure, if you have an overbite for 5 millimeters, you can go for logical thinking, you open 3 millimeters. So that would be something like a rule, but there is no law or there is no rule because everybody is individual, of course. And when we see this situation, we could say, okay, this now we have, we could do now here an ideal speaker, okay. And in this situation, we see the big step from the already abraded canine to the premolar. And this is also a sign where we can know that the vertical dimension is not ideal. And so this is the real case. So these are pictures from before. And this is the situation with the splint. Okay. Now, you could ask maybe why we do the splint in this case in the lower, or in other cases we do it in the upper arch. So imagine we do this splint in the upper arch. We will have a big problem here because the splint will block the movement completely. If we come from up to down here, we block it. But now here, because if I go back, we can see clearly that big step and that the height is missing in the lower. So clearly we go and make the splint or lift the bite with help of the lower, or in the lower arch, or lower or in the mandible. After a while of wearing the splint, the patient gets used to, or the muscles get used to. We start wearing the splint overnight. That means just for sleeping, because the patient will, like even a scissor, will have first contact when you give him the splint only on the second or last molars, because the muscles are not stretched yet. So they need to get slowly, but step by step, they get used to the splint. That's why for 10 days about we wear the splint only overnight. During this time we can modify or idealize the splint or adjust. So normally we use splints like this, very simple. Most of the time we have a free front. Why? I will show you just later with the live demonstration. So I show you this case now, which I have now here in the Artex. It's a fully adjustable articulator. And when we see, we fix this, you can fix it with a face bow, or you fix it just let's say an average way, which for a technician is not a big problem. So we can take this out because it's just a reference where we will have the middle point, or the incisal upper meeting point, let's say. And we see here we have absolutely a deep bite. And we can measure from the vestibulum to the vestibulum, or we can measure from this cervical border to the lower cervical border. And we measure, when we say we have, the one is 38 to 40 millimeters. Oops. So here is 38 to 40 millimeters, and here is about 18 millimeters. Okay? So we can measure this, and if I measure, here I have 32 instead of 38 to 40, and here I have 13.5 instead of 18. So what I go now, I say, okay, I go 4 millimeters, just I start this way. And I can see again, okay, I was down here, and now I'm down here. So this is about, I can still go more to have this 2 millimeters 2 millimeters overbite. This is the logical thinking. When you just play with your articulator, and at least a master technician should at least be able to do this very simple. Okay, so we open now the bite for about 5 millimeters almost. Let's see, yes. And now what we see is the overjet cannot be correct anymore. When we know an ideal overjet, and for that we have a screw here and this articulator where we can screw, and we go and we open here, okay. We have a lock here, and we open and we can move our mandible forward. So let's go for 2 millimeters in protrusion, because when we open, as we know all, our DMG is not, it's not working like a scissor. You have a little rotation and then a movement forward from the condyles. So when I see now this situation, I see, okay, because of moving in the protrusion, I lifted it automatically again, so I go back to my ideal, let's say, ideal overbite, and I can see from the side, I see, okay, I have an ideal overjet. So what we do next is we have to lock for this articulator, because now, because of protruding, I can move now here. Okay, and this, we don't want to have this movement. So we open, it depends the articulator, but in this it's very simple. We have this screw here, and we go the Bennett angle to 0. Okay? And you do the Bennett angle to 0 all the time, also when you do protrusion movements and frontal guidance, you at least go on 0 with your Bennett angle. This you need only by a side shift and not straight protrusion. So now we have fixed this position, the articulator is stable, and in this position, okay, we do now a splint. A simple splint which has not a locked, we don't want to have a locked occlusion, we want to have freedom in centric, let's say, like to have freedom movement, and this splint is made, you can mill it, you can print it, and you can do it a normal manual way, like we used to do splints since 50 years. And then you have this splint position in the articulator, and now the patient is wearing this splint only in the night for about 1 to 2 weeks. And now, why also here, we could have done this splint in that case, we could have done in the upper jaw as well. But we are having here a missing tooth, and we see already what's happening with the second molar. And again, we would create an interference even with the splint if we do the splint in the upper jaw. This is one point. The second point is that we have now also a stop even for this second molar in our splint. And the steps are now, the patient is going with the splint, he sleeps with this splint, and step by step the muscles are getting the new position, getting used to. We don't want to stress the muscles too much, so that's why only in the night, where the patient is not playing around with his splint in the mouth, and after 2-3 weeks we can tell the patient if everything is fine, wear the splint almost 24 hours a day. If the patient is doing this and the muscles get a new program, they get a new automatically position, and we see that, or the patient will tell us that all the symptoms, we are surprised sometimes how many different symptoms are just leaving overnight. It's funny sometimes, or very impressive. And there if you do things like this, you do much more than dentistry. You heal muscle systems, you heal hip tilted hips, and so on. Because the goal finally is, the aim is to do this for the muscles, because we have one muscle chain, and all our mastication muscles are influencing all the rest of our body muscles. And that means we try, of course, or what we bring with the splint therapy, we bring the mandible in a, let's say, in a symmetric position to the head, or to the upper jaw, or to the cranial finally. That means the left and right muscles, they are having the same length. And when they are guided by canine and frontal guidance, then everything will be fine. And you treat the patient with starting by the splint, and after the splint, you could really go and, like for this case, instead of a splint, we have here, as you can see, just the prefabricated or the milled, in that case it's milled occlusions from Edelweiss. With the digital, you have the natural tooth. There is no grinding, no prep necessary. It's just in the milling machine produced. So you see, it's very simple, and it's also then for when you work this in the mouse or you fit it in the mouse, there is only one position possible. It's only time fitting perfectly, and this is already taught in the 60s by Professor Gerber in the University of Zurich, that when we do a splint therapy, the splint is just a therapeutic tool. It's just for a temporary time. It's never the solution. The solution would be when you bring a splint, what the splint is doing in a permanent mouse situation, and this is the easiest way how to do it, for my opinion.
You mentioned measuring the cervical of the incisor to incisor. Nowadays we see a lot of patients, like the first patient, Thomas Turner, bruxing, where the teeth are quite short.
Yes.
I think the way you explained that would work perfect for those type of patients when the teeth are very short, and if we measure it maybe say 12 millimeters, and then we need to get it to your ideal of 18 or so.
Yeah.
This method of yours would work perfect.
Yes, because it's so a closed circle, because you start with the splint, that gives you the guarantee that you're on the right position. It's a test also. It's not only the therapy for the muscles, or because the muscles need their time to be in a new position. It solves with the splint. You can also prove to the patient that it's fine, and he wants to have this position all the time, and not only with the splint. And so it's easy to explain the patient, because he feels the advantage he is living now, and he wants to have this in a permanent. So we have this with these occlusions or that's just the easiest way, and so minimal invasive and cost efficient. So it's a win-win-win situation somehow. It's for all. And if however something happened, you easily repair it because of the material, and the mechanical properties are ideal for our antagonists, for example, and so on.
Another big advantage, especially when we're opening the vertical dimension, is that you don't want to put too much of pressure on the TM joint. So when you start using materials like zirconia that has 1,200 megapascal flexural strength, it's a bit too harsh for the joint. Whereas with the Edelweiss system, it's got this little bit of modulus of elasticity that's similar to tooth.
Absolutely. We are much more closer to the nature, and because of the mechanical properties.
Yes. So it's ideal actually. It's an ideal material if you want to raise the vertical dimension using the Edelweiss system. Because of that give and the flexibility, you're not going to cause any TM joint problems later. You don't want to open up the bite and 1 year or 2 years down the line the patient has severe TM joint problem that is even you've worsened the situation. You've made the patient worse than
that's not our
so you don't want to do that.
Of course not.
And the way that you will prevent that is using the Edelweiss because of that material that's giving forgiveness.
Absolutely.
If you go with strong ceramics or zirconia,
it causes more chipping because maybe the patient is still working in the night, because if this typical bruxers, anyway, for them we have still, also after, we give them a thin splint just for sleeping. Because if you are just bruxing like this, you will not stop just like this. And then you protect, or you do just a little splint, or a very thin soft splint, then otherwise splints where you do all the time in a hard material.
So following the Edelweiss system, once you've opened up the bite, then with the bruxer you give a very thin soft splint just
only
to protect.
Let's say like a nice guard.
But
a thin one.
So that just to give that little protection, so that there's a little sponge in it.
Because then he can react. We know that our mastication system is directly connected with our nerval system, and so all what is let's say stress psychologically. We have children in school before an examination, they start already to Brooks and so on and so on. So we have much more Brookses today than 50 years ago. So this why these solutions, we have many patients where we can help them by this way.
You know, whenever I lecture all over the world, this is the most common question that I get asked by dentists, is how to open the bite, how to fix with the new bite, and their biggest fear is they're scared they're going to cause some tear and joint problem. So with your way that you've explained it, to use those measurements to open it, so you've given them some guideline now on how to open it, then you've used the material of Edelweiss that will protect the joint, so that you don't have any fear of having TM joint problems later.
Yes. Yes, absolutely.
And
It's
with the
also
Braxa,
preventive.
you can do an extra sort of precaution of putting a soft splint over.
Yes, for the night, after the treatment and all,
Okay.
finally.
Okay.
Of course, the position of the condyles, they are changing also.
Yeah.
So they
Yeah,
come
it can-
out
yeah.
of the, they take distance to the bilaminar zone,
Yeah,
they
yeah.
take a little bit distance to the cranium.
Yeah.
So they come like physiotherapists and they talk about free zone. They
Yes.
don't talk
Yes.
about centric, they talk about free
Free
zone.
zone, yeah.
So because it's more or less muscles
That's
which are
exactly,
moving and
yeah,
which
yeah.
are
Okay.
checking everything, and the muscles are finally protecting also, of course, the joint.
Yeah.
And we have a stereo
Yeah.
joint,
Yes.
and that makes it complicated.
Yeah.
But if you go this way, you will see it's not complicated at all. It's because if you do it like this, it's just logical.
Yeah.
And you do it really with basic knowledge.
Yeah, well, the way you explained it, it seems very. If you follow that step by step, it's not too difficult to do.
And I guess everybody could do that. Every dental technician or master dental technician, they learned what's ideal. They just need to bring it in ideal. And just with a splint. So you don't take risk.
Yes, that's right.
It's
yeah.
a safe.
there's no risk.
It's just a splint,
Yeah,
you know.
yeah,
It's not
yeah.
expensive, and you will prove the patient the advantage,
Yes,
what's
yes.
changing.
Yeah.
And when they feel they're changing, they don't want to get back to their migraine, for
Yeah,
example.
Of course, yes, yeah.
And we have migraine patients, they start with the splint and they have no migraine
Suddenly it's
anymore.
just gone,
And
yeah,
it's
yeah.
just, wow, it's done by the dentist.
Yeah, yeah,
Wow, come.
Yeah.
You know, they were everywhere already.
They were
No, really.
MRIs for the brain and everything else, but they come to the dentist
Yes.
and you fix the problem up just by doing this.
Yes.
And of course, I think at the end of the day, you have to use the Edelweiss veneers or the restorations, maybe because of the forgiveness. Otherwise, if you put
We
something
do all
strong,
with- we
yes,
do-
yeah.
we
Now
do
what I'm
all
saying
with,
is, you cannot restore it with any other material because then you're going to get the migraine again because you pounded
The
the joint
hardness,
again.
yes, the hardness of the,
Yeah,
the biomechanic
Yeah,
is
it's-
here
it's-
very
it's- yeah.
interesting and very big advantage. Big
Yeah,
advantage.
So-
Yeah.
So the way is splint, Edelweiss system because of the mechanical properties, and if we need a splint again. So I think
For a
that's
Brookser.
for a
If
Brookser,
you're
if
a
we
really
need
strong
it,
Brookser,
if
we
you
had
need
these
it.
cases already where we had also to learn, okay,
Yeah.
you will not easily stop Brooksing.
Yeah.
And to protect
Yeah,
our,
of course, yeah, the restoration.
our
Yeah,
restoration,
Yeah.
we give him a thin layer splint,
Yes,
soft,
yeah.
he will not even feel
That
it.
makes a lot of sense, yeah.
And-
Also, you break the cycle that at night
Yes.
they want the upper lower jaw
Absolutely,
cycle.
yes.
So you're actually breaking
Yeah,
the cycle, yeah.
exactly.
Another very big advantage of the Edelweiss system, if it does fracture or you get a chip, it's very easy to repair in the mouth.
Yes, yes.
All you need to do is just roughen it.
Just roughen,
And
bonding.
you put the Edelweiss bond on there, not your normal bonding
No,
agent.
yes.
Yeah, Edelweiss bond, and then you put some of the Edelweiss hybrid composite and contour that, and then light cure and polish, and that's
Yeah,
it.
that's it.
So it's unlike ceramics, which is very difficult to repair in the mouth. You know that.
Yes.
It's I need to
And-
redo it or.
And you have no loss of, you don't make a loss of cosmetics or something. I mean, it's wonderful, beautiful. You cannot, by the eyes, you don't see if it's ceramic or
Yeah, of course.
Edelweiss.
Yeah,
You know,
yeah.
it's not visible.
Yeah, yeah.
You must grind, then you
and then you
see,
can see the
okay,
difference.
yeah.
Absolutely.
Or this you can throw through the room.
Yeah.
It won't break the ceramic.
Okay,
You can search different parts.
Yeah. Well, I mean, you just dropped one now and you picked it up and put it.
Yeah.
There's no problem.
Yeah, nothing happened.
Nothing
Yeah.
would happen. But a ceramic would chip. We know that.
Absolutely,
Yeah.
yes.
Yeah. Well, I mean, from your experience, you know that
Absolutely, yes.
ceramics will chip.
That happened to me. In ceramic, just finish and it tongue and I start anew. I had to start from zero.
So then brings me to the point. Stephan says that if there's a possibility that it can get stickier, so it can make it a bit too sticky. Yeah. So probably best to stick to the technique that we teach is to just roll it with your fingers and warm it up. That's probably a better way to do it. As I say, I don't think it's necessary to go for an additional step when this step we know has been working for many years and thousands of patients have done it. So why change something that's working?
I saw Stephan, I don't know how many 100 times already, and he never heat the materials up. So because between the fingertip, the material gets already softer because of the temperature of the fingers, and in the mouth on the tooth already, it's also, we have the 36 degree. That's more than enough for this thin layer of composite to be smooth and soft enough. So you don't need to heat it up especially. I mean, we are not in a norm again, so there is not a law where I can say, but we have this, I mean, we had cases where we opened the vertical dimension for 10 millimeters already, and nothing happened, so everything is fine. It's just a muscle thing. It's just about muscles, and we adjust then the occlusion to this point. That means finally our occlusion is our mandible position is depending to the occlusion, and we idealize the mandible position and adjust the occlusion for this. So we change the occlusion in case of make it ideal. And what is ideal is, I don't know, in Austria maybe 10 million different, because we have 10 million people. So everybody is different. And we have this average where we say a vertical dimension, it depends where you measure. If you measure from subnasal point to the pogonion or vestibulum to vestibulum, it's about 38 to 40 millimeters. And when we have a case where we have only, because of a deep bite, where we cover the whole lower front, you know, with the upper front, then sometimes really we open for 8 millimeters, 7 millimeters, just we go that far till we have a nice overbite and overchat. The rest is not so, it's just this logical thinking. When you have a master dental technician, he should have learned this, he should know what is ideal and just bring it in ideal. And ideal means sometimes 5 millimeters, sometimes 1 millimeter, sometimes more, sometimes less. I cannot tell you, you have to go all the time 5 millimeters or 2 millimeters. It's when you have it in the articulator by a maximal habitual bite, because this is our bite. I don't need a check bite or anything because that does not change the bite, you know. So this is all the time habitual, maximal or habitual bite. That means maximum intercuspitation. And from this point we start to idealize with the articulator. That means most of the time we rise the bite, we lift for. To say, let's say we have an overbite of 1.5 to 2 millimeters. 2 millimeters overbite is fine. And then if we do that, of course, we create the bigger overchat. And that means we protrude the mandible, we go forward till we have a nice overchat. That can be 1 millimeter, 2 millimeter. We did already 10 millimeters. So, you know, we are not, our DMG is not fixed somewhere, like our knee or our elbow. Our DMG is completely free. We move in all 3 dimensions, stereo. And that makes it complicated, but if you think logical and you play with the articulator, it makes it so logical and easy. This was okay for you?
Yes. Can I just add on to that, Gene? Yeah, this is a question we get asked all the time. And in fact, yesterday, Martin and I were discussing this. The question is, how much should we open the bite? Let's assume that there's no teeth at all in the mouth. So we have a vertical dimension of 0. Because if you get the patient to bite, there's no teeth at all, so it becomes 0. But then now we need to open it with your wax when we make a full denture to about 40 or 48, 50 millimeters. Yes. So we open it quite a bit because there's no teeth in the mouth. But once his teeth starts to reduce itself, then we take that difference of what has been reduced. So depending on how much has been reduced in the mouth, we add to that. So starting from that point of assuming that there's no teeth, going to 50 millimeters or 48, then we start adding up. The other point to note is that there's a rule called 1-2-3 rule. So if you open the pin by 3 millimeters, the anterior teeth will open by 2 millimeters, and the molars will open by 1 millimeter because of the way the jaw is positioned in a wedge. So the more you open in the front, it's less in the back. If you think of a wedge, so if I open 3 in the front with a pin, the incisors will open 2 millimeters and the molars will open 1 millimeter. So that needs to be taken into consideration as well, because most of the times how we determine how much to open is by the incisal line. So if we're using, going back to the digital smile design system, we look at the lip line and then we look at this where your incisors should be positioned. So then we work out that difference. And let's say the difference is 2 millimeters. Then we need to open the pin by 3 millimeters. So you get 2 millimeters in the front, in the incisors, and it only opens 1 millimeter in the back. Is that make sense to me?
Yes, that makes sense. That makes sense. So because when I do the frontal pin, the incisal pin, when I lift the incisal pin, it's the articulator is then like a scissor. But our DMG is not a scissor. It has just a little rotation and then it moves forward. So that's why when we open the frontal or the incisal pin, we have also to move the mandible forward. And because of our condyle inclination, automatically it gives that our condyles are pulled out a little bit of their position. And that's not a problem for the TMG. It's just because it's just muscles what we treat or change. It's the muscle position. And that it's most of the time a big advantage for the muscles. But we have not the rule. It's every case is individual. And you start mounting it a habitual way, habitual bite, maximal intercuspitation in the articulator. And with the knowledge of overbite and overchat, you already arrange your case. If you're a dental technician who knows how to work with a fully or a semi-adjustable articulator, who once learned how to do a full mouth denture, to make a speak curve, an ideal occlusion, or with a wax up, however, he will come to this result finally, automatically, with using his knowledge. Because with the help of the articulator, you go and check the overbite. Then you forget about vertical dimension. Just check overbite and overchat in the articulator. And when you do then in this position a splint, you're fine as well. Because you know what's perfect. When I have a patient, which a perfect or ideal would be 5 millimeters. And I go 4 millimeters. That will be fine for the patient because that's much better than the 0 where we started from. Finally, what we do is muscle treatment. We do finally physical therapy by changing the occlusion for the mastication muscles, by bringing the mandible in a symmetric position that we have left and right muscle pairs same length. If they are then guided by canines and front incisors, then everything is fine. Then you cannot do better. Then it's perfect. Then what all the symptoms which are depending from there are leaving automatically. But you don't make it too complicated. Really, just see overbite over chat. And change it in the articulated just to watch overbite over chat is ideal. You can protrude, you can lift the vertical dimension with the incisal pin, and then you do a splint. I think that's the easiest explanation, because then you don't need to make things too complicated with measuring vertical dimension. You can do that to be sure that you see, okay, when I did this, what I explained before with my articulator. Do we see this articulator now? Here? Okay, on the picture. So when I go back to I need to take off the splint from the model. I go back on the protrusion to 0, back to the thing, basic. So this is the starting situation now, okay? By this way we start. So we see we have a deep bite, okay? And we know what's the ideal overbite. Is it 2 millimeters, let's say. So we open like we have this, let's say, overbite of a little bit more, of 2 millimeters, okay? What we have now, we have a too big overchat, because what does the articulator do? He is like a scissor. Okay, but our TMG, this is not a scissor. So what we have to do is we have to protrude the mandible forward. So what we can do with the screws, we do left and right side the same. We move in that case like till we have an acceptable, okay, more, even more. We can go 3 millimeters if I don't see it here. Yes. We do left and right, all the time we do the same thing. So now I have a overbite and overchat. And now on this position, I do a splint again in the lower, because I have here a missing tooth, and I want to support also that tooth, and not to have any more interferences. That's the whole magic thing. That's really simple. And if you do it like this, you can then go you can go and measure the vertical dimension, which I have now, which should be here about 18. Yes, I have 18. And from vestibulum to vestibulum, it should be 40, but I not. No, I have about 39, 38. So that automatically, if you follow up this, then you will have a good result.
The question is, can we use Edelweiss veneer with patient that has bruxism, and if after splint therapy, does this follow that the patient will stop bruxing?
We had already this situation where we had the bruxer and then they stopped bruxing. We had patients, they were bruxer and they did not stop bruxing. Okay, so because bruxing is not depending on occlusion or something, the bruxing is, it goes deeper. Bruxing finally is something in your back of your mind, in your unconscious. That means your mastication system is connected with the vegetative nervous system, and all stress, all psychological thing, dream, whatever can bring you to bruxing. So everybody sometimes is bruxing. Okay, maybe you have an examination tomorrow or whatever, then you have your stress and you react. Your mastication system works this stress out, let's say. And with new occlusions, you will not stop the stress. So that means you should, in that case, when you have strong bruxer, you give them, as we mentioned before, you give them a thin, soft splint. It's like you have these splints for bleaching. You know, you can take a material like this and you protect then the patient can work, he can react, and you protect the occlusions, because then it doesn't matter. Only if it's full metal jacket, then this will be, that will not chip. But every other materials would chip. If it's ceramic or even zircon, I saw it breaking easily, you know. And because the forces of 200 kilo massator power kills nearly everything. That's why then, if it's have these strong bruxers, we need to give him a night guard, let's say, a very thin, as you use for bleaching splints. That works well, and then your restoration is safe like this.
Okay. Can I ask again for you both to repeat how it is done when there is fracture of Edelweiss? Because earlier the audience cannot hear your discussion.
Okay, so if you have a chipping or a small fracture of a cusp with the Edelweiss veneer or occlusion, it can be done chairside. All you need to do is to roughen the fractured area. By roughening it, you're actually also removing a little bit of the smear layer that may be caused from the saliva. So once that's roughened, you then apply, you blow dry that, rinse it and blow dry it, and then you apply Edelweiss bond to the roughened area. It is important to apply the Edelweiss bond only, not your dentine bonding agent. The reason for that is the dentine bonding agent that you use conventionally on your teeth has some hydrophilic portions and water as well that would sit and there's nowhere to go. And that will cause some discoloration as well as can cause some debonding. Whereas the Edelweiss bond is specifically made to bond to the Edelweiss system. So you need to apply the Edelweiss bond onto the fractured area, then you lightly air dry, and you light cure that. Once you've light cured that, then you can apply your Edelweiss hybrid composite to the fractured area. You can contour it to the way you want it to get the proper anatomy. Once that is done, you light cure that for the composite, and then you can use your polishing cups to final polish. The way the Edelweiss system is made, the composition of the hybrid composite and the veneers or the occlusion VD as the same components. So when you do a repair like that, you would not see any fracture margins or any white line that you would see when you're repairing, for example, ceramics or any other system. This has the same components, so the margin itself will be aesthetically, you wouldn't see the difference. Does that answer your question? Martin, do you want to add anything to that?
I have a follow-up on that.
Yes.
If the fracture has tooth exposure, do you need to apply the enamel dentin bond on the tooth itself and the veneer bond on the Edelweiss?
Yes, you need to protect the tooth for sure. So you need to apply your conventional bonding agent to the tooth, otherwise the tooth is going to be sensitive. So you need to seal the tooth as well. That's quite important. If you apply the Edelweiss bond on the tooth, that's not going to work because it cannot go down the tubules. So it's important to use the dentine bonding agent on the tooth and Edelweiss bond on the tooth surface. Sometimes it may be a very small area, but you need to do it.
What is the typical causes why Edelweiss must fracture so that we can prevent doing this?
You didn't understand. Could you please repeat?
What are the common factors of why Edelweiss may fracture?
Okay, yeah. So what are the usual causes of fracture? Okay, so yeah, okay, fine. when you specified for Edelweiss system. Okay, Edelweiss system does not have specific causes of any fracture. It doesn't fracture on its own. It doesn't have any weakness that will fracture on its own. I must put that very clear. It is a very strong material. We've tested it out. It's similar to lithium disilicate in terms of flexural strength. So it doesn't have any inherent weakness on its own. So there's no reason for that to fracture. So that's the first thing that I need to point out. The second thing that I need to tell you is what are the causes of fracture of restorations in general. What I find most of the times, not just with dentists, even with my students at the university, when they complete a restoration, whether it's veneers, occlusion, or whatever, the final step is to check the occlusion. Now, most people, what they do is they check the occlusion in static occlusion. In other words, they put the paper in, the articulating paper, and then they get the patient to bite, tap, 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 and see where the high spots are, and then they grind that off and send the patient off. But what actually happens is, when the patient goes home, he's not just tap, tap, tap and biting in static, he's biting in dynamic. In other words, there's lateral excursions as well. So it is very important to check the occlusion in dynamic occlusion. In other words, you need to check incisal guidance, you need to move the lower jaw forward so there's no interferences in the back. And whether it is lithium disilicate, Martin just mentioned he's seen zirconia fracturing as well. How can zirconia fracture? If you think about it, it'll fracture if there's an interference. If the interference is there, no matter what material you put in the mouth, it's going to fracture. So you have to check incisal guidance to make sure there's no interference to the lateral excursions as well. And of course, canine guidance in lateral left and right, there should be no interference. If there's any clipping, I can guarantee you whether it's zirconia, no matter what material, is going to break. So that is very important, that it's not just an Edelweiss system that will break, it's no matter what material you put in the mouth will break. A fracture of a material does not depend on the strength of the material, it depends on if there's any interferences, occlusal interferences to the mouth. Okay, you want to add anything to that?
Yeah. What I saw, or what I was read once, it was a study from German dentists. They found out that 80% of the fractures are on the second molars. So, and what I found out is that, especially because of myself, when you have a second molar crown, for example, and you feel at the beginning when the crown gets fixed in the mouth that it's too high. Most of the time you grind, and most of the time you grind too much. And that means that you have an infra-occlusion. That means the antagonist has no contact anymore in a normal habitual bite with his antagonist. Okay? So what you do in the night, especially in the night, you search this contact. So you start to force this crown, because you reach, of course, the contact, because you can move your mandible in this position where you push to the crown. And you you kill this crown by over 200, 250 kilograms, which are working here. And there is the material, only a full metal can support this. But this is also an infra-occlusion in the second molar area. The patient will search. He's not thinking about this. It's automatically. It's because of the sensitivity or of the censoring of the parodontium, where you want to have the contact to your antagonist. So if not, in the night you search this and you force this crown, and they can chip or will break.
And so we have started already getting quite a few bookings already for next year's workshops, and this is what we're going to run from next year, because of course, as you know, that 2020 we couldn't do any workshops. So we're starting our Edelweiss Academy of Excellence again back next year, and we will be running short courses, like for example 3 days, where we will do hands-on workshops, where when you as an attendant or a delegate We'll be working with models. We'll show you exactly how to place the veneers on models itself. And we will do lectures starting right from the veneers to the material science. And Martin will also be here to discuss occlusion. You can ask him any question you want to, and he will demonstrate with the articulator as well. And then Stephan will do a live patient at that time, so you can watch live patients. These are short courses, roughly about 3 days, that you come here to Austria, to our center here at the Edelweiss Center, and we do that for you. Then we're also going to run next year a master class. There you will be a master aesthetic technician qualified by Edelweiss Academy. This is a longer program where you will be sitting hands-on, you will be assisting Stephan, and you will be watching how he does it on a one-on-one basis, okay? And of course, we will repeat all the lectures. We will take you to the laboratory. Martin will give you a full demonstration on how to open up the bite, so you'll feel confident when you finish off with the masterclass that you can handle these cases when you leave us here. So that's what we have planned for next year, and already as I said, a couple of countries have already booked with us, and we expect it to be quite full. And as you can imagine, we cannot take too many delegates at one go because we want to give that hands-on one-to-one lectures and talks. So if you are interested, contact Jean and Hung, and they will set up the bookings with us here. Okay, so you want now for Martin to repeat yes?
I would allow me to follow up what
Okay.
you just said for Asian delegates, because before we screening for Asian delegates by just buying the kits, but we cannot do that anymore, and this will be your last opportunity be able to join us in terms of having experience an Edelweiss workshop in Austria. Of course, I hope the delegates will understand that discounts with the cost. So the last registration for those who purchase the Edelweiss kit and would like to have a free training next year in Austria will be on December 15th. So for the next following workshop in Austria, this will now come with a fee. So that's it. Thank you so much. Okay, Dr. Desi, you may proceed with Martin if he can repeat again the part of
Okay.
the muscle.
Okay. So Martin, you're going to do it the third time now.
So you mean this part of the presentation? Because I haven't...
Are you going to do these slides? Yes.
Yes, okay. Yes. So, yes. So this is just the case. When we get in the lab or we have the models, we analyze the occlusions. And in this 18-year-old patient, we see already these strong abrasions. So it's a typical bruxing situation where we have here really big decays already and strong abrasions. And we see the next step picture. You see the same case, and you see now here the abraded, completely abraded canine, okay? And then the big step down here to the premolar. And if you already only see this, you will know that this is a deep bite position and the vertical dimension should be raised or is not correct. And this is an example which I shown before. This you have here the same thing. We have the canine here and you have the big step. So this is not an ideal spay curve, okay? So what we do, again, when we go back to the articulator, we see, and if you have a technician who knows what's ideal, then he is able to change this position in the articulator, and you could ask for a wax up, however, but you will have this vertical lifted dimension at the end. So when we talk about things like this, you know, we have this, when you see this is it's just a perfect example for an interference, okay? What this happens is if this patient is chewing, he is chewing all the time on the left side because on the right side he cannot move because he is blocked here. And what this is caused to the muscles. So the problem will be on the muscle side because the muscles have also the job to protect the joint, okay? So the muscles they do everything to protect the joint. That means they go all the time, they go around this rock. And now they do a splint, which is not the solution. The solution would be just eliminate or extract, put out this rock, which is on the way for the muscles. So that means the muscles want to move around, you know, ovite when we chew. It's like when you watch a cow, you know, it's ovite chewing. And if you eliminate this, you have already solved the problem for the patient. So sometimes it's a very, very primitive, or let's say very easy and logical, a pre-contact. Or like this third molar. So sometimes it's just model or analyzing. What you see on a model, maybe you don't see in the mouth because you cannot look from the back, you know, orally. You cannot see these abrasions which we see here on the mouse because it's shiny, it's white, it's reflecting and so on. And that's why we make study models. On the study models we see a lot of things and we find out sometimes it's just selective grinding and the patient will be fine next day already. If we do this, if we bring this out, 1 week later the patient will be a new person because this little thing is making horrible problems for the muscles, again for the muscles. It's not for the joint, it's muscles, because muscles protect the joint as long as possible. And again, if you see this case, which I repeat now, you see that this is not an ideal spay curve. We have here the second molar. Here should be another tooth. There is no place. So it's so logical. If you see models and study models, you will find out very easily and logically by knowing of vertical dimension, of knowing basics from dental technicians, then you can change with your articulator. You need, it doesn't matter if it's SAM or Artex articulator, it's a semi or fully adjustable articulator, doesn't matter, it's just important that you know how to use it. That's the point. And then you go and idealize the case. You just check what's overbite, over chat, and that you can make with the articulator. And what you do, you see, now we have a nice overbite, we have a nice overchat, but here we have to do something, and it's missing in the lower arch, obviously, because you see, again, the big step from the canine to the premolars, and we know spay curve, so this has nothing to do with a spay curve, which is ideal. And this is the real case now, so we did this some years ago already, 5-6 years ago, this case. Yes, and this is the splint which we did in the lower arch, because if we would do it in the upper arch, we will block again the movement of the patient, and it's missing on the lower arch, the height. Okay, so I will have to change to Stephan now, yes, because I think it's already done. Yes, we switch over there. Thank you.
So, in the meantime, I have placed 10 veneers, so we went even both sides to the second premolar. As the discussion was going on so fruitfully, I just went on. Of course, it's always optimizing the further we go back. So I'm in the last step now, just to finally polish. And I think you could follow up on all the steps I did. So now as I said, I'm just going with the green polisher. So they are diamond infiltrated. This is my initial one. And actually after that, I will just go with my high shine polisher. What you notice is that, of course, the veneers, they are not only sintered on the surface, they are sintered throughout, so from inside, outside, completely. And of course, that allows me to also work on the surfaces. Today, I keep it simple, but of course, you know, while you are doing a system or working with a system, you might progress and say, okay, now I want to individualize the surface, characterize it, etc. And that's all possible. So you can adapt the surfaces and repolish it to the same gloss as it had at the very beginning when you took it out of the box. So now, once I have done this with my green, I will just show you how immediately the shine turns back when I am using my gray polisher. So now we could solve many issues with our patient, because in one way we have, as you can see, the gingival line relaxed. We have solved the misalignment of the teeth. Of course, this could have been also done with orthodontics, but we all know now we have a patient which is already an adult. She don't want to wear braces anymore. At the same time, she looks for immediate result. And again, as we work so minimally invasive, she can have that all in one session, as we can see now, with our veneers, as the veneers allow us to bring everything into the position it should be, and at the same time provide her with a new shade, like a nice color. And of course the shape of the tooth was also corrected, which of course would not be corrected if we just go for orthodontics. So now I'm just using my gray polisher and finish everything off. Just a little bit of water spray at the same time. And you can experience this amazing gloss. It's really the composition of the material, this barium glass and also strontium, is just mimicking nature in a very beautiful way. Remember, I have used the A0, so we have a very bright and light shade, but probably most of your patients also today requesting very light shades like B1, A1, etc. Top it with an A0, for example, as we did today. But still, even though we worked with this very white opaque material, due to the fact that our veneers are translucent, they are transparent, like the natural enamel, we always have the illusion of deepness, which means the transparent part allows the light to blend in, and of course the more opaque part is reflecting it back. So we have circulation and reflection. And that, even though we use very white shade, looks very natural. Now at this very stage, everything is a bit brighter. We have just done the case. And just now by visual observation, you can see this beautiful shine we have. I just will move her a bit, then you can see the light reflection. So very natural. As I said, now the teeth are still very dehydrated, so you won't get the shade immediately. It will take a bit. And the saturation of the shade is taking place within the next 2 to 3 days, and then we have the final shade. But now if you just look how shiny, how beautifully shiny all this is. And that's also, of course, because we are having a laser sintered structure, a pure glass structure with a Laudet. Nur trocken bitte. And once again, beautifully shiny. And if you observe the gingival margins, I mean, we have now seated 10 veneers. 10 veneers, how many hours? Maybe 1.5? 1.5, yeah. So can you imagine, 1.5 hours for the 10 veneers? Of course, there is a little bit of pre-work. As I said, I did the gingivectomy before. I took an impression, so I had a study model available. From the study model, I could already adjust the veneers properly. So just to go back, this is my study model, and my veneers I already adjusted length and width-wise on the model. So that's why I could follow up straight, tooth by tooth, on the case itself. So if you are prepared for such a treatment, then you can do, as I said, these 10 within 1.5 hours, which is quite amazing. But of course, we are not on a race here. We just take it easy. But as you see, everything is very relaxed, and we can still work on the case. I mean, it's not like a ceramic veneer, which we should not touch at all. In this case, we can really adjust, fine-tune, remove if there is something too much. But I think the result is quite nice. Maybe we can just show once again the before picture, because this is also what the patient forgets the first, once he sees his new result. But now you have the comparison where we started out, and of course we will also look at her reaction. So I will also use my mirror just to give you also a view of the incisal. And so this is it. You can see, so very nice integration. There's still a little bit from the blue paper color as we check that. And so now this is a starting point. Okay, when you close for me, please. Right, right, okay. So also fine. As we said, we're going to follow up with the lowers as well. But now I'm going to remove. And now, of course, the lips come into place. And our teeth are like actors. And, well, I'm now checking on the, 12 o'clock view, the distance. And if you give me a smile. Yes, very nice. Yeah, it's quite nice. I'm quite happy for now. Then we bite again. Close again, please. Okay. And now just leave it very slow.
Ganz locker.
Local.
Ganz locker.
And it, local and umgeschieben. So now also we can see that we have this canine guidance, you see. And there is very interesting. Now we talked all about the bite all the time. And you see how much she has eroded that party here. And of course, that is communicating with the upper. And this is what we're going to, of course, also solve once we do the lower. So the idea really of these veneers is in a way that we coordinate canine guidance, proper function, so that we have a steering wheel from the front for the entire mastication at the back. And that goes together. And of course, if we work with a biomechanical material, so now these veneers, they become part of the tooth. It's monoblock, which means if there is cold and hot, if there is forces, the veneers together with the tooth can absorb them together, distribute them together, shrink the same way, expand the same way. So they're not fighting against each other like we would do the same thing with a zirconia or ceramic, because the behavior is so different. So the secret of the strength of this material is mainly in the biofunction. Like a Formula 1 car, the chassis is not made with steel or iron. It's carbon, it's flexible. And that's, I think, a very important approach for these kind of treatments, to be able to bring back function and top it with aesthetics. So should I bring the patient now up from a front view so that she can see herself? And this is now also always interesting, the first reaction, the experience of the patient when they came in, like we have just seen on the previous picture, and they go home with the one we show you now. Okay. Du musst ja noch legen, sie ist ganz komplex. Ja. So of course, we didn't provide, veneers which are arranged like a piano. there is still a natural look, there is still the character, let's say this individuality of the patient, which of course works with her, you know, cheeks, with her nose, with her eyes, everything comes together. And just remember the before, I mean, we will summarize that anyways, but of course I think to have this done within 1.5 hours or 2 hours, 10 veneers, very easy for the patient. We didn't numb her, we didn't have to prep the teeth, just slightly roughen them. As I mentioned, the one central which was so much exposed, I had to remove a bit of the decay first, and also I did gingivectomy. And that allows us to have now nice gingival lines, as we can see also now when you look at it, that's just, you know, very much leveraged, even though we overcame that. So we can do a bit of magic with those veneers. Of course, it's all about training, about getting the tricks, and this is why Dr. Mudli mentioned you are always welcome either in Austria or in Cape Town at our clinic to do courses, to have, you know, a day, 2 days, 3 days, a week with me and my colleagues who are doing these cases on an everyday basis, and then for sure you will be in the position to achieve what I did. Here it's less to be an artist, here it's more to have a precise protocol and to work according the steps, but at the end what you provide is aesthetic dentistry. So that's from my side. If there is any further questions, please do not hesitate.
In cases of diastema, will this be a strong material, still, especially on the lower teeth, where is the biting force?
Yes, you see, actually, when we look at her teeth right now, then of course we have also these kind of gaps, yeah. But especially with diastemas, it's what I close so often, you know, that I have centrals which have big gaps, or laterals which have big gaps, or over the whole front. So as I said, it's important to know once that material is merged and, let's say, cemented with the tooth, it's one system, it's one setup, it's a monoblock. And so if there is forces, if there is contacts, you know, it can absorb it. It's like a shock absorber. That's also the beauty with our CAD/CAM blocks, or let's say the possibility to do immediate load with implants, because the material is mimicking the buffer which we normally had from the bone. And this is what we lose using zirconia or also ceramics, I mean, especially when we have functional cases. But as I said, diastema cases, doesn't matter, you can always do that. Important is to have the canine guidance, as I have checked, because then you will always have the stress release from the central and arterials, and nothing can happen. So absolutely yes, for diastemas, for all these different variations which we find, and also like bruxers, etc., which we just heard, all this is absolutely possible.
Another question, on the current case, the left central incisor have a different gingival contour. So which height of the gingiva did you follow when fixing her two central teeth?
So I remained with the gingival height of the 21, as you see, of 21, and I followed up gingivectomy on 11, 12, and I even went a bit to 13, and I followed up also on the other side. So I did that on both sides. You know, the thing is also here we have a bit of a forgiving situation, because if she gives us a very bright smile, you don't see her gingival line. So I could have also said, why should I, you know, don't waste the time or something. But you know, it's not only that we do it for the patient. We want to go happy, and we want to see the best result we can do. And to do a bit of gingivectomy, it takes no time, but it makes such a big difference. As I said, I took the 21 as my reference, and I cut it back. And well, at the same time, that allowed me to harmonize and to relax the overall situation now for her.
Okay, so when was the gingivoplasty was done?
Well, I have to tell you the truth, I only did it this week, Tuesday. And this was due to the fact that we had initially another patient lined up, but then due to COVID and restrictions, you know, we had some difficulties to get that patient in. And then we were happy because, of course, we have lots of patients waiting, and then she was ready to join us today on a Saturday. And so I just called her in. I said, listen, we're gonna, you know, do you first. And then I quickly followed up with the gingivectomy. And I did it with the electrotome. So very easy. And today, this morning, I saw her and I was happy because within 3 days, you know, we have a gingiva, which was a little bit slightly, you saw a bleeding. This was mainly based due to the fact that I did that, not caused by the mylar strip or that I, you know, damaged anything. That was just that slight, very slight on the surface still. But and now, as we have all seen, the gingiva already, you know, it looks beautiful. And within 2-3 hours, we will not even see that she had a treatment, you see. Now imagine, if we would have used cords, if we would have gone subgingival and so on, I mean, that would involve prep, and it would now look horrible, you know, it would look like a fighting field. And this is the beauty with that mylar strip technique, which is simple. Of course, you know, it isolates, and it was giving me the right position, or let's say enter, for my veneer, and that makes it simple.
There's another question. If the patient requires splint treatment, how long do you normally wait until you place veneers to the patient?
Well, that's mainly about 3 months. So if we have someone with a deep bite, or even like say a bruxer, we raise it. As I said, we only take situation models. So actually I see the patient, making sure his hygiene is good, so that of course all comes into place. That's, I think, in modern dentistry just state of the art. And then of course I take impression, I share that with Martin. Martin is analyzing then in the articulator the right height and so on. So I get the splint, I seat the splint for the patient, and the patient has it for about 3 months. That's the time it takes until the brain, you know, switches to the new height, because every time we close, it's like a reset on our computer. And now the reset is done on a higher level, as well as the muscles are adjusted and worked out to be balanced. And then, of course, I can just proceed taking the splint out, giving it to the lab, then either asking them to mill everything from the CAD/CAM blocks, which of course is very, very convenient. Also, the lab likes to use the Edelweiss CAD/CAM blocks because they can produce those crowns or veneers or whatever, occlusional veneers, within more or less than an hour, because you see, they don't have to glaze burn or sinter or whatever. When that block is milled, it's just polished and finished. And again, not critical, because if there is something, I can always roughen and add if there is a problem. But anyways, so I get the stuff, and then I, of course, clean, edge and bond and place. So especially for those patients who have experienced crowns and bridges where heavy preparations were done, of course, they are quite surprised, because in the end they see you probably 3 times, but you only do once real, you know, application of veneers or crowns, whatever, because you haven't had a prep done, as long as we do not need to prep. Of course, we also need to prep, also place crowns, but you know, we do all our works either with blocks, veneers, or the occlusions for all our patients.
Okay, don't go over the 3 of you. I will just present shortly a reminder for the participants, and of course, we would also like to hear from the patient. Just give me a few minutes to share
Kannst du
something
Englisch?
to the
A little bit.
participants before we do the final words. And of course, I would like to invite
Wie es für die ist und wie dir das jetzt gefällt.
Ja, voll gut, was soll ich dazu sagen?
Kannst du das auf Englisch sagen?
Anyway, participants, we would really like to invite you all on this design meeting contest that we started last January. And of course, we would like to see your before and after photos of your something from the patient herself, how she felt, and what do you think about the entire treatment. And thank you for your participation of allowing us to watch your treatment today.
I thank for all, and I'm very, very happy. I thank for all community Edelweiss and my doctor Stephan for give me this beautiful love, and thank you. I'm happy.
Okay, so Martin, any last message for our participants before we go?
My last message for the participants is, I hope you come and join us in Austria, that we meet us together and that we can have this pleasure to see beautiful smiles and beautiful results. And yeah, just come to Austria. That's the great thing. Thank you.
Okay. Dr. Desi, any last
Yeah.
inspirational words for our participants?
Firstly, I must say thanks to Stephan and the patient. Excellent results. In 1 hour, 15 minutes, we can achieve this is really wonderful. I think this is, it's to do it the traditional way is very difficult. We have to cut teeth, send it to the laboratory. It's 2-3 visits. It's more expensive. This is such a beautiful result. I think we have a wonderful, happy patient that's going to leave here. That's what I said when we started off. We're going to, from the time we started, first see the patient till the time the patient leaves. That's what we wanted to do, step by step procedure, and I hope you as delegates have enjoyed that. We tried to do it a little bit different. Instead of doing the formal lectures, we thought we'll do it this way, that we'll walk you step by step and have a discussion between Martin, Stephan and myself. I hope we've explained everything that you needed to. And but I'm going to say what Martin just said, that webinars are fine. We can reach far audiences without traveling, but at the end of the day, we need to meet you. We really like to meet you, and one-on-one we can have discussions and become friends. So we invite you to come over next year, and we will entertain you, and we will do the same thing. We'll have a patient here, and Martin will be with us discussing. We'll take you for a tour to the lab, and he will show you how to do all the vertical dimensions, and of course Stephan will show you the clinical side, and I'll do the scientific and lecture side. So you're more than welcome. I hope you can join us, and once again I hope you enjoyed today's discussion. Thank you so much to Jean and Hong and the entire team for putting this together. I know it takes a lot of effort to put something like this from Austria, Philippines, Malaysia, wherever Singapore delegates are coming from. Thank you so much for being part of this Edelweiss team. Last
Thank
words.
you.
Thank you, Dr. Desi, and of course for the last words of our CEO and the inventor of Edelweiss, the star of the night, Dr. Stephan Lampl.
Yeah, well, you see, my weekend, of course, is solved, absolutely. At the end, this is the biggest gift we can provide to a patient, but at the same time to ourselves. Yes. If we have someone smiling at us after such a treatment, which is really changing her life, it's also changing our life on an everyday basis. So we are really privileged to have learned this profession and to participate in these cases. And all what we have done, it looks always simple, I know, when I do it, but it is as simple as it looks. And when you come here, or let's say we come to you, we will see how we're going to do this in the future. But as I said, in Cape Town as well as here in Austria, we have the possibilities to do those master classes, and then you will have the same opportunity and make people happy like us, and so we can all be happy. So I wish you a fantastic weekend. I thank you for all the time you have shared with us today, and I hope that we're gonna meet soon in the future somewhere in this world. Thank you.